Next, I invite Dr. Akshaya of Sunrise Eye Hospital, medical retina consultant, to talk on the art of injecting anti-VEGF injections.
Thank you, Anu. Good morning to all. So, as we have gone through the chemical composition and the different types of anti-VEGF injections in detail, now my task is to describe the right technique of giving intravitreal injections. So, as we all know, intravitreal injections, they are known for their quick and targeted therapy. They allow you to achieve therapeutic levels locally, causing minimal side effects to the patient. And they have become almost become an indispensable part in the lives of retina specialists. They are so widely used these days for the management of diabetic macular edema, in CMEs involved in vein occlusions, AMD, PCV, in the treatment of neovascular glaucoma and ROP. And we have a wide range of injections available in the market, and with the influx of biosimilars, they have become so much more affordable to the patient, and because of which the number of injections being given have increased dramatically in the past few years. So we all know that giving intravitreal injection, it is an easy breezy job. It does not require much of a skill to give an intravitreal injection. But then there are few things which needs to be emphasized, which have to be kept in mind before, during, and after giving intravitreal injection. And first and foremost is getting an informed consent signed by the patient and the bystander. Even though it's just an injection, we need to get an informed consent, which should include the disease for which the injection is being given, the name of the injection, and the possible complications that could occur following an injection. Secondly, counseling of the patient. Very important to let the patient know the nature of the disease in the eye, why they are getting the injection, what to expect from the injection, and the reality that they may need multiple injections in the future, and also they may have to switch to a different drug during the course of treatment, because you don't want the patient to come back to you saying, doctor, I got one injection, I already got 2 injections, but I still have the disease in the eye. So in most of the diseases, we all know the aim might not be to get a perfect 6x6 vision. It might be just to maintain a reasonable, decent vision in the eye. Third point is topical antibiotic. It is again controversial. There is no foolproof evidence that giving intravitreal antibiotics prior to injection can prevent endophthalmitis, but I think most of the doctors prefer to give topical antibiotics at least 3 days prior to giving an injection. And then every step during while giving injection should be done under thorough aseptic precautions. And any active lid infections should be looked out for and should be treated before giving injections. Any hordeolums or blepharitis, everything should be treated before giving intravitreal injection, because these could be a strong source of infection following the injection. Now, preparation of the eye. Instillation of 5% povidone iodine in the conjunctival sac is an accepted universal practice, and it has been strongly recommended for the prevention of endophthalmitis following injection. So in our setup, after instilling povidone iodine, we also give a nice lid scrub with a cotton bud soaked in 5% povidone iodine. Both the upper and lower eyelids are scrubbed nicely. And to give an injection, all we need is a pair of cotton buds, a caliper, a speculum, then an insulin syringe, a 30 gauge needle, and a longer needle to withdraw the drug into the syringe. While you withdraw also, we should make sure that everything is done under aseptic precautions. You have to draw 0.05 cc, a little more extra you can draw, because there some amount of drug can go into the subconjunctival space as you withdraw the needle. Now the technique. So the quadrant that you choose for the injection is totally up to the surgeon. whichever quadrant you're comfortable with, you can pick. So I am a left-handed person, so I prefer supratemporal quadrant for the left eye and supranasal for the right eye. But then most of the people, I think they prefer inferior quadrants, because the patient always has a tendency to roll up their eyes, to squeeze their eyes, so it's more comfortable for them to look up rather than look down. But then one small advantage of giving a superior, choosing a superior site, is that small subconjunctival hemorrhages that could commonly occur could be masked by the upper lid. So you can save the patient getting worried the next day seeing that bright red spot in the eye. Otherwise, it's totally up to the surgeon. Whichever quadrant they want, they can choose. And it's always better to get the eyes dilated before the injection, so that you can see the needle as it enters into the globe. Now, you take the measurements using a caliper. Measurements are taken from the limbus, 3.5 mm for the pseudophakic eye and 4 mm from the limbus for the phakic eye. So once you take the measurement, using a cotton bud soaked in paracaine, you can gently retract the conjunctiva at the site of injection to avoid any vessel if present. And then with your dominant hand, you go perpendicular to the globe, directed to the center of the globe. It's important that you go perpendicular to the globe, because if you tilt anteriorly, there is a high chance that you touch the posterior capsule. And then once you inject with your dominant hand, you slowly withdraw the needle and then immediately keep a cotton bud over the site of injection for a few seconds, and then that's it. You can put a drop of topical antibiotic following the injection. So any procedure comes with its own set of complications, and anti-VEGF injections are even they come with their set of complications. So they do have their drug-related and procedure-related complications. Drug-related complications, there is a very rare chance of thromboembolic events, stroke, myocardial infarction, renal diseases following anti-VEGF injections. And procedure-related complication, as I said, the most common is development of subconjunctival hemorrhage. Nothing to worry for the doctor, but scary for the patient. The patient will get obviously scared seeing that bright red spots in the eye, but then all you have to do is tell the patient that it's going to fade away in a few days. The second complication that could occur is development of corneal epithelial defect. This usually occurs when the patient, under the effect of anesthesia, they tend to open their eyes under the iPad, and then the iPad rubs over the cornea. So if the patient complains of pain the next day, day one following the injection, most probably it's going to be due to an epithelial defect. So again, it can be treated easily with copious lubricants. It's going to heal in 2 or 3 days. Third complication is development of cataract. As I said, it is because of the wrong technique of injection. If you tend to tilt the needle anteriorly, there is a high chance you touch the posterior capsule, and it can result in development of cataract. And there could also be an acute rise in IOP following injection, but then usually it lasts for only few hours. So it's always advisable to check the IOP following the injection and treat accordingly. And finally, the most dreaded complication, which nobody wants, is endophthalmitis. Although the incidence is very low, 0.019 to 1.6%. If the patient complains of pain, redness, photophobia, lid edema, following injection, usually they present 2 to 3 days following the injection, then that should raise an alarm. It is an emergency, and definitely it has to be referred to a vitreoretinal surgeon for to treat accordingly. So that's it. Thank you all for your patient listening.
Thank you, Akshaya. That was a very informative talk. And 1 second, I have a question for Akshaya. Is there any preference to give the steroid injections regarding the quadrant to be chosen?
Steroid injection also, when I give Ozurdex and all, I prefer supratemporal for the left eye and supranasal for the right eye. And then I don't I have never given any special importance to steroid injections. I usually choose the same site which I choose for anti-VEGF.
Okay, thank you.
Do you give bevacizumab now also?
Bevacizumab, yeah, we do give, because we in our place Not all patients go for biosimilars also. So there are few patients who do not afford biosimilars also. So then we do give, we do
So
give
you give
bevacizumab.
with
We
the
still give.
consent, you take a separate consent, like
Yeah,
this is
and we
off-label.
mentioned that, it
It's
is
an
off that
off-label.
we mentioned,
Thank you.